my name is Dr. Brinen. I'm an assistant professor at Drexel's College of Medicine in the Department of Psychiatry, where I'm really fortunate to lead and direct a center where we study recovery-oriented cognitive therapy for psychosis, as well as disseminate and get to work with youth-blind people. And so I'm really, really excited to be here today. In my very weird and long journey from into the work that I do today, along the way, I actually went to school to treat PTSD, right? I wrote every paper in my doctoral program on post-traumatic stress disorder. My dissertation was on post-traumatic stress disorder. Really what I was supposed to do is go off and treat PTSD in the VA for the rest of my life, be home in time to take my kids to swim team. And I was actually just really lucky. You know, there's a great song by Garth Brooks says, some of God's greatest gifts are unanswered prayers. And so I'm here and doing this. But the love that I had for the work of helping individuals with post-traumatic stress disorder is still there. And so the approach that I was really fortunate to learn in great detail, and one of my mentors and dear friends is one of the creators of prolonged exposure. So Monday, we got to enjoy and spend time thinking about post-traumatic stress disorder and really, what is it really? What actually more about what maintains it, what keeps it going. And that was a lot of our focus on Monday. And today we're going to spend some time thinking about how do we help individuals with post-traumatic stress disorder, and particularly the individuals that we normally serve who also have psychosis. And so the focus of today's talk is really going to be around exposure therapy. So we're going to review really quickly some of the psychological theory, sort of enough to get ourselves in trouble in it, but the bulk of today is going to be really talking about what do you do. It's not intended that you'll be able to go and do prolonged exposure. The goal of today, hoping, is one, to sort of like tickle your interest in in prolonged exposure or exposure therapies in general. Also give you a little bit more of an off the paper feel for treating people using exposure therapy. I'm guessing, or I really hope every one of us on this phone when we were in school learned about exposure therapy, maybe even learned about exposure therapy for PTSD. But I find that oftentimes what we learn in school misses the nuance of what does it actually feel like when you're sitting in a room and doing it with somebody. And so this is really one of the things I absolutely adore, is doing this work. And part of the reason I really adore doing exposure therapy is I've really found that in my life, I've watched this show for years. It's called Good Eats. I don't know if anybody has ever seen the show Good Eats. And there's it's really a filmmaker who became a chef named Alton Brown. And he always talks about, he doesn't like unitaskers in the kitchen. And essentially a unitasker is a device that you get that only does one thing. And so he really feels like they're useless. They crowd your kitchen out. And so when I do therapy, I'm not a big fan of unitaskers. I don't like doing treatments or engaging in protocols that only get you one thing. And I'll tell you that one of the things that I'm going to really come back to over and over again is that exposure therapy is the opposite of a unitasker. Exposure therapy is not teaching somebody one thing that they can use in one moment, hopefully once. Exposure therapy is a way of living your life and learning how to sort of approach life in a much more assertive, present way, which is why I absolutely, I love the treatment. Not saying that it's always easy, and we could talk a little bit about that too, but it is something that I really love. So going back to sort of the understanding of PTSD, if we really think about what is PTSD, the best way to think about PTSD, or a real simple model for PTSD, is to think of it as a phobia to a memory, right? We all know phobias, right? So phobias are like, you know, I'm afraid of snakes. You know, if it says snakes that way, I go that way, right? Pretty simple model. And for the way that the world works, it's interesting. One of the most effective treatments we have in all of our psychological treatments are the treatments of phobia. It's probably one of the most effective treatments we have that nobody uses. The reason is this: those simple phobias you can avoid. If it says, you know, if I have to take an elevator, I could take the stairs. If there's heights, I could say no thank you. It's really easy, and people with phobias, simple phobias, which is sort of a phobia toward an identifiable stimulus, you can avoid and you can construct your life where I don't need to take planes and I don't need to do these things. And so it can get really, it can be easy to do. And usually people get their phobias treated when all of a sudden they can't avoid anymore, right? So all of a sudden you get this, like, you know, $100,000 a year promotion, but your office is on the 100th floor. So those days of taking the stairs and being the best, you know, worked out person ever are over. And so now all of a sudden you have to do it, right? And so that's when people come to get their phobias treated. The problem with a phobia to a memory is wherever you go, that memory goes. Right? You can't avoid memories, right? The idea of thought suppression is really ineffective. The more you try to push it out, the more it comes back at you. So in PTSD, people avoid the memory of the trauma, and then they start to avoid the reminders in their environment of the trauma, which makes sense because avoidance works in the short run. When I avoid something, I feel better. I feel relieved in the short run. But in the long run, it maintains the fear and actually can make it much worse. And so what happens is the more that we avoid, the thoughts and beliefs that we hold on to are unchanged because there's no new data to help change them. Avoidance is going to limit the activation of the trauma memory, which sounds like a good thing, except the only way that we can process and work through a trauma memory is if we activate it. It limits our ability to incorporate corrective information. I mean, and again, if we think of the brain as a filing cabinet, right? So let's imagine that our brains are like a big filing cabinet, and there's files in it for everything. You know, if you go to the restaurant, you know, you open it up, take out the file, you open it up. You have files for every type of restaurant, and it's easy to start comparing which, you know, was this time better, was this time worse? The problem becomes with PTSD is that essentially the trauma memory kind of gets shoved into our brains, right? And we have no way of really starting to work out what is, you know, so it gets just sort of shoved into the filing room. So there's little bits of it throughout the filing cabinet. So when you open up the file on restaurants, the trauma memory pops out, right? When you go to the store, the trauma memory pops out, right? So there's all of these things that's sprayed all around that remind us of the trauma memory. And so what happens is we just start to avoid things over and over again. The only way you can clean up a file room is if you go into the file room, who wants to do that? Sit down in the file room, who wants to do that in a messy file room, and systematically go through and sort out the filing room, right? And starting to bring in some corrective information about what may have happened. The only way you can do that is sitting with it. Every time you avoid it, you stop incorporating new data. It's, you know, the more we avoid it, the less we start to make sense of what actually happened. A lot of people feel like they know what happened, but ultimately they're oftentimes missing huge pieces of what happened. So avoidance, while it feels good in the short run, it maintains the trauma-related associations and those beliefs in the long run. It just keeps us stuck. And when we're talking about how avoidance and psychosis works, right, avoidance leads to more hallucinations and delusions, right? Because you're not doing stuff and you're staying at home. But hallucinations and delusions are going to lead to more avoidance. And ultimately, hallucinations and delusions can lead to more activation of the trauma memory, which makes us want to avoid more. And so we end up in this horrible, horrible cycle. And so there's really nice research out of Kim Muser that shows that there's a big relationship between the avoidance symptoms of PTSD and the increase in hallucinations and delusions and psychosis. So when we're thinking about, what are the beliefs that a person might be holding on to when they've had a trauma and when they have specifically PTSD, they're frequently seeing themselves as incompetent, the world is excessively dangerous, and that the future is going to contain more danger. So whenever you hear me talking about sort of the generic formulation, this is what I'm talking about. If you know that somebody has PTSD, even if you know that somebody experienced a trauma, these are sort of like, these are sort of the usual suspects, right? Pull those out, poke them in the back of your head, and start trying to prove or disprove them, right? Gather data to see, does this person see themselves as incompetent? Incompetent meaning I couldn't do things, I can't keep myself safe, I'm always in danger. The world is excessively dangerous, right? So everything out there is really, really dangerous and I can't be helped. And I'm likely to get hurt. So when we're thinking about psychosis and PTSD, the reason we want to take care of the PTSD is that it really provides that uncontrolled source of stress. And it really, again, me being a guy who came from PTSD over into psychosis, one of the things I really started to recognize is that if you think of psychosis, if you think of the idea that PTSD and depression occur together so frequently that we always measure depression when we're treating PTSD. And then you think of the hallucinations and delusions and the negative symptoms of schizophrenia. I've oftentimes sat in my office and talked with people about, they really do share very similar shape to them. Right? So the hallucinations and delusions are the intrusions, and then the negative symptoms are, the depression and not doing stuff. And so they really do sort of mimic each other really quite elegantly, which is why they work so well together quite elegantly. The hallucinations and the intrusive memories, all of the sensations provide excessive amount of stimuli that the individual can misinterpret, but the person's also constantly hypervigilant. So they're like the Hoover vacuum of data. And so just lots of opportunities for misinterpretation. And then all of the beliefs and schema around shame, guilt, anger, grief, they all can become voices. They can become themes of delusions. We can see this all playing out really, really repeatedly when we're talking about when psychosis and PTSD come together. So like I said last time, we always say, we start with the protocol, right? Activating individuals, right? Getting them engaged, that reduces the defensiveness. Aspirations, right? We really want to see where we're going. And even if you're treating somebody with PTSD who doesn't have psychosis, in the work that I've done when people have PTSD, I'm very frequently making sure I have really rich aspirations, because when I suggest that we might want to do exposure therapy, a lot of people understand why, and they're like, I get it, and they're like, I don't want to do it, right? And I don't force them to do it, but we just have a conversation. But when we put it in the context of moving toward the things that you want in your life, these things that are really valuable, it becomes this sort of North Star that guides us to where we want to be in our lives. And so then all of a sudden we can juxtapose the pain and the distress that we might experience during, really the distress we might experience during exposure, because you're not really experiencing pain, but what we might get in the long run. So let's think about the strategy for change, right? If I'm going to sound as old school CBT as I can. So when we're talking about the strategy for change and we say, why would you want to do exposure? The reason is this, one of the things, this is the emotional processing theory that was developed by Foa and Kozak, Edna Foa and Michael Kozak. And sadly, we lost Michael, I believe it was last year, but Edna's still around. But essentially, they developed this emotional processing theory, which is this theory about how does any fear work, right? So there's this idea of a fear structure, right? In a fear structure, we have sort of these structures in our mind all the time, right? You know, if you see a bear coming, you go that way. And so there, you know, each fear structure has the stimulus, it has our reaction, and it has the meaning of the stimulus and the reaction, right? So if I see a bear running at me, bear equals danger, right? I have a reaction. I run and scream at a really high pitch, which is true. And the meaning of it is bear is dangerous, and I am, you know, I am in danger, right? That's normal, okay? We should all have that fear structure, or a semblance or a version of that fear structure. Fear structures really become pathological when we have two conditions that develop. Right? So when they're pathological, they have an excess of stimuli in them, right? So everything sets off that fear structure. And they have really rigid and excessive meanings, excessive reactions. So high amounts of avoidance, and then excessive meanings, right? I'm totally incompetent. I'm completely in danger. You know, nothing's ever going to be better. And so all of those pulled together, the trauma memory is a specific form of fear structure that we develop in our mind. The fear structure around the idea of all of the stimuli that might have been present during the trauma memory get encoded into the trauma memory as a fear structure. And so, for example, there's obvious logical things. If I'm in a car accident and, you know, cars are going to get coded in, no brainer. You know, headlights might get coded in. That's not a surprise either. But what about, you know, the smell of honeysuckle? Why would that get encoded in? Well, I might have been driving with the window down and I smelled honeysuckle as I was driving along, right? Why does the color yellow freak me out? Well, the yellow is what I saw on the street. I saw the yellow lines on the street. So while there are really logical ones, it's also the ones that set it off that don't make any sense whatsoever. And then there's excessive responses, usually having to do with avoidance. Before we go any further, I said this on Monday, I'll say this again today. We are going to be talking about PTSD. I'm not planning on being particularly graphic in it. And in the end, when we do questions, I would encourage other people to be. That being said, PTSD is about traumatic events. And we all, right, as we learned on Monday, 60% of us have experienced a traumatic event in our lifetime. So just be gentle with yourself, be comfortable with yourself. If all of a sudden you're finding that this is becoming way too overwhelming, I will post this. I will try to post this faster than I've been posting them. I've been a pokey puppy. But please just take care of yourself. And if going through this in bits and pieces is easier, I absolutely understand that. So there's two essential features that we need present in order to alter a fear structure. Fear structures, especially when we have a high amount of avoidance, are really good at keeping themselves in place, right? So one of them is that we need to activate the fear structure, right? Let's use an example of fear of heights, right? I could tell you how safe you are, you know, when you're on a high, you know, about heights. I could talk to you a million, you know, for hours and hours and hours about this, you know, that people are really safe when they're high up. And you know what you're going to tell me? Great. You go and stand on top of the building. It's not going to change your fear structure at all the more I just try to give you lots of information, because what we need is we need the fear structure to be activated. And listen, if you're an old school CBT person, that's what we were talking about when we talk about the hot cognition. We need to activate the thought. It needs to be active in order to do it. And then we need corrective information. And it needs to be incorporated into the fear structure while the fear structure is activated. So essentially, we need to feel pretty anxious, and then we need corrective information while that's happening. It all needs to be in the context of the fear structure while it's activated. So a couple of wonderful quotes that I saw. Jonathan Abramowitz, he once said, I saw him at an ABCT conference. He said, exposure is the best cognitive intervention, right? So it's a wonderful way to change your cognitions is through exposure therapy. Dr. Beck once said, cognition changes in the crucible of affect. It's a very Dr. Beck thing to say, very kind of beautiful. But it is that idea that our thoughts change when we have affect. And then Steve Holland, who's down at Vanderbilt, said behavioral experiments are the most underutilized cognitive intervention. So exposure therapy is this learning through doing process. And so it's really simple. It's really easy for us to understand, right? The conclusions are simple. There's not a lot of like mental, gymnastics that we're going to be doing in order to learn from exposure therapy. A lot of people talk about like, well, what about comorbid, problems? Won't people get worse? Don't they explode into fire? All that stuff. And there was a great review article in 2012. There's lots more information now to add to it. And they looked at every reason why people say don't do exposure therapy. Dissociation, borderline personality disorder, psychosis, suicidal and non-suicidal self-injury, substance use disorders, and major depression. And what they found is there were really no contraindications for any of them. People got better in all of those situations, right? There's a lot of great work that Melanie Harnett is doing out of Washington State around borderline personality disorder and exposure therapy. And so what they find, though, is that people are able to do just as well. A wonderful researcher out of Australia, Rachel Brand, did this really smart review, the smart meta-analysis. What she found at the end of this article was that exposure therapy, when you're trying to do psychological interventions, that exposure-based therapies are the best therapies for individuals with both psychosis and PTSD. Right, so she really found that it worked. A really wonderful study that came out of the Netherlands, where they compared prolonged exposure versus EMDR versus waitlist for people with post-traumatic stress disorder and psychotic disorders. And the interesting thing is they found that these individuals were much more severe than some of the other cases that they had been seeing. That didn't matter. That PE did prolonged exposure. Did just as well as and EMDR basically were neck and neck. They both did equally well. They said, and they have a bunch of other studies. Essentially, the only mistake you can do is not treating the PTSD. That was their message. The only people who got worse were the people who didn't get their PTSD treated. And so it's this resounding message again and again. And if you really think about this idea, and this was something that came up on the end on Friday, which is this, people go, well, aren't we going to put the thoughts into the head? Are we putting the trauma memory into their head? Are we activating? Are we triggering them? And the answer is a resounding no. It comes down to the idea of understanding how PTSD really works. PTSD, by its definition, means that the trauma memory is in your head all the time anyway, right? If trauma memory is not in your mind all the time, then you kind of don't have PTSD, right? And I'm not trying to be funny. I'm like, it's really legitimate. The difference is that in exposure therapy, we're systematically and predictably helping somebody move toward this memory. In PTSD, it comes at you whenever it wants to, and it's completely random. And so it becomes terrifying. And what happens in exposure therapy is that you master it. You are able to grab the memory and enter into it as you choose to, as the individual. It's a really powerful medium. And I really want us to think about all of the other parts of psychosis that we've been talking about over these months now, I don't know. But think about it. How great would it be for any of our individuals to learn that you can approach the things that make you uncomfortable in your life? And approaching things is better than avoiding. It's a really powerful lesson for a person to learn. So let's go through the treatment structure of exposure therapy. We're just going to go through it. We're really going to be talking specifically about prolonged exposure. That's the version of exposure therapy that I learned, I grew up on. They do have a second edition out. I get no money from it. My name is not anywhere on those, right? So there's Edna, Lib, Barbara, and Sheila. So I get nothing from it. And so they don't even thank me when I mention it. So they don't like send me text messages. So whatever. But they're just Liv Hembree is just she's my mentor, and she's just a wonderful individual. So if you ever get a chance, but it's a really, I have to tell you, the treatments that work series is a great series. The PE manual is really approachable and really good. And so the second edition, they've updated a lot of their research to incorporate the new things that they've learned after studying this like forever. So the components really fall into a couple categories, right? So there's a hefty amount of psychoeducation. So I think a lot of people go, you're just going to start exposing them? No. I say it this way. By the time somebody starts exposure therapy with me, they know as much about exposure therapy and habituation and anxiety disorders as one of my students leaving sort of like a Psych 101 class. So you learn a lot about habituation, right? So that's really good. So you have a lot of psychoeducation and a lot of psychoeducation about the experiences that you might be having. There's in vivo exposure, right? So that's sort of approaching things, sort of real life exposures where you go out into the world and you sort of start approaching these reminders that are objectively safe, but you just don't do anymore because of the experience that you had. And then the workhorse of this intervention is imaginal exposure, right? It's revisiting, where it's not reliving, but it's revisiting the memory in imagination. And you do it for a really prolonged period of time. That's why it's called prolonged exposure, right? And so for the first time you do it, you actually revisit the memory for 60 minutes straight. And you retell the memory over and over again with your eyes closed, with a lot of imagination. And I know I'm imagining some of the people's eyes just went like this and got like saucers. We're going to talk through it and how it actually works out. And then processing, right? If you're using exposure therapy for habituation alone, it's like buying a Rolls Royce to move your manure. You're really missing the benefits of having a Rolls Royce. And so it's really important. We're going to talk about how the processing, the importance of processing, but that's where those cognitive shifts happen. So rationale, right? So we're going to start setting the stage for the individual. And like I said, the first 3 sessions of prolonged exposure, if you go and learn how to do it or you buy the book and you read it, and I do encourage seeking out some supervision. I think if you go through PE like 2-3 times and you get through the whole thing and it works pretty well, you kind of learn where all the bells and whistles are, and then you can just call a friend if you have, if you struggle during one spot. It's a pretty straightforward intervention. We start by setting the stage with people, right? So there's different factors. We tell people, listen, when it comes at following a trauma, lots of people react in lots of different ways. Some people get stuck and other people don't get stuck. We don't really know why. All true statements. But we know that if after a year you don't get unstuck, you're likely not to get unstuck without a little help from somebody like me. And so the bad news is you've got this thing called PTSD. This is Barbara Rothbaum's line. The bad news is you've got PTSD, and that's a horrible way to live. The good news is we have a lot of plan A's. We actually have 3-4 wonderful treatments that are really, really effective. And so if this treatment doesn't work, another treatment's likely to work. So that's the good news. And we really feel confident in saying that we believe that you can get back to this life that you want, and these memories aren't going to haunt you the way that they've been haunting you. So we talk about, there's 2 main things that keep you stuck, right? We avoid the memory, we avoid the reminders of the memory, the things in our environment that have that remind you of the memory. And that we also start to, trauma changes the way that we think about ourselves. We start to see ourselves as incompetent and the world that's as excessively dangerous. But if you see that the world's really dangerous, everything starts seeming a little scarier, right? And if I see myself as incompetent, even the smallest things start to look overwhelming and dangerous to me. This is the question I asked on Monday. So if avoiding the memory is keeping you stuck, what do you think is going to unstick you? And the answer, every one of the individuals I've asked that to, I don't want to say everyone because I'm sure somebody else didn't say this, but pretty much unanimously I get not avoid. I go, right. We call that exposure, right? We're going to start to revisit the memory, and we're going to revisit the things in your environment that remind you of the memory. We continue to go through it, that exposure to memories and the situations, it's going to let you process and organize it, right? And all throughout these rationales, we just start giving people a really, I use a lot of metaphor, right? So at this point, I might even use the file cabinet room, but it's just gonna let you organize the memory. And a lot of people say, well, I think about it all the time. I go, yeah, yeah. So when you think about it, is it like a book flies off the shelf and the worst part of the memory opens up? And they're like, yeah. And then do you slam the book shut and push it away as fast as you can? They're like, yeah. I go, so what we're gonna do is something different. We're gonna pull the book out. We're gonna read the front of it, and then we're gonna open it up. And we're gonna go through one page at a time and read each page, right? We're gonna read the good pages, right? The nice pages, and then we're gonna read the scary pages as well. And we're gonna read through every single piece of it, and we're gonna see what we need to learn. And the things that we're gonna learn, that a lot of people learn from it, is that memories in and of themselves aren't dangerous. The trauma, the event you went through was very dangerous, but the memories actually can't hurt you. And that many of these situations that we've been avoiding are actually not dangerous either. And so we don't need to avoid those things either. We're going to learn that anxiety and distress decreases after repeated and prolonged exposure to it, that your anxiety is going to come up and your anxiety is going to come down. And frequently, as I'm explaining this to people, I'm pulling on the experiences that they've already talked to me about in therapy. And ultimately, we're going to notice that exposure reduces PTSD symptoms. So the first part, right? So in the first session, we're going to talk a lot about that. In the second session, we're going to start, by second session, we're doing in vivo exposure. We're going out into the world. And the in vivo exposures are largely done as a part of homework, right? If somebody's really struggling with in vivo exposures, we might add that into and do it in session. We might go and do some of these things in session, but largely we're doing it as a part of homework. And so the lessons we want people to learn as a part of an in vivo exposure include that anxiety is predictable and ends, right? That anxiety goes up and anxiety comes down, right? That anxiety is actually pretty tolerable, right? It feels crappy, but you can tolerate feeling anxious. That the avoided situations are actually usually pretty safe. That avoidance isn't the only way that we gain relief from these things that are scaring us. So there's a great story that that a lot of PE people use to explain in vivo exposure. So I'm going to share it with you now, and I'm absolutely guaranteed that it's in the book. It's called Boy on the Beach. And so the way the boy on the beach goes like this. One of my colleagues, she took her son to the ocean, right? And they were down by the beach. Obviously, this is pre-COVID. So she's down by the beach and the little boy is playing on the edge of the water, perfectly safe. And a big wave comes and knocks the little boy over. He gets, understandably, he was surprised, gets really scared, runs over to his mom. Mommy, no water, no water, no water. She picks him up, washes him off, kind of brushes off the sand. And he's really beside himself. Mommy, no water, no water. And I'm curious, what do you think that she should do? Do you think it would be helpful for her to go, well, he's upset, let's just go home? What do you think would happen if she just picked him up, packed up all the stuff and went home? Right. He would learn that he should be afraid of the water. And the only way you feel better when you feel anxious is if you avoid those things. So she was really smart. Like I told you, she was a colleague, and she, which probably then means she was also an exposure therapist, but she kind of thought, she goes, okay. So she goes up, all the way up by there was a boardwalk. And so she walks along the boardwalk with her son. And predictably, as they're walking along, his anxiety goes up. He goes, no, mommy, no water, no water. And she just keeps walking. And what do you think happens as they continue to walk along the boardwalk? Right. The anxiety goes down. And so they keep walking along, and every time his anxiety goes down, she just gets like 1 or 2 steps closer to the water, right? Then all of a sudden they come off the boardwalk and they're on the beach. Every time they come down, what do you think happens? Right, she gets more upset. No water, no water, and they continue to walk. But as they walk, what happens? Right, his anxiety goes down. And every time his anxiety comes up, they just keep walking and the anxiety goes down. And before you know it, he's back in the water and he's playing. So what are the things that the boy learns from these experiences? Right, one, that you don't need to avoid or go away from something in order to relieve your anxiety. That anxiety is pretty predictable. This anxiety would go up, but then it would go down as well. And then he learns most of the time, water isn't dangerous, right? Most of the time, nothing really happens when you're playing by the water, right? As long as you're safe and doing the things you're supposed to be doing. So that water in and of itself is pretty safe to play along, just like he had been doing before. But those are not the reasons I advocate and I really believe in exposure therapy. What that boy learns when he goes and he faces his fear is that he learns something about himself. He learns about the power, the capability inside all of us, but he learns that it's inside him as well. That thing that he was so afraid of, he's no longer afraid of. Right? That he was able to overcome something that made him genuinely afraid. So he feels proud, he feels capable, and he sees that he can approach anything systematically. So then what did the mom do? Right? There were three main factors that made that successful. Right? It was predictable. She didn't just chuck her son right back into the water. It was predictable. Every time she made an action, it was predictable what they did. It was prolonged. She did it for a period of time so he could feel his anxiety come up, but then the anxiety went down as well. And it was repeated. They repeated this learning experience over and over and over again. So prolonged, repeated, and predictable. All of the things that we do in any intervention should be repeated and predictable. And especially when we're doing exposure therapy. So he learns that he's about his own competence. Think about the value that would have for the individuals that we serve who have both psychosis and PTSD. I think it could be, I know that it's one of the most valuable lessons that they learn. So then after that, and this is the part that usually gets people a little like, I don't want to say freaked out, but they really go, whoa. By the third session, we're starting imaginal exposure. The first session is an introduction of the rationale, a little bit of assessment. We teach a relaxation technique just to try out between sessions. The second session is in vivo exposure, and we're going to talk about common reactions to trauma. And then the third session, you come in and you do another rationale, right? There are three rationales that you give. There are three sessions where you give rationale. But by the third session, you're doing the imaginal revisiting. And a lot of people go, that's fast. And I will tell you, the longer you wait to start your imaginal exposure, the longer that person's sitting with PTSD. And so I've done this with really some of the most severe cases I've been fortunate to partner with people about, and getting right into the imaginal exposure. Also, they kind of know why they're there, so waiting ain't going to make it easier. So that brings us to imaginal exposure. So the lessons we learn in imaginal exposure is the idea that remembering the trauma is painful, and leads, the rationale is that remembering the trauma is painful and leads to avoidance. But the idea is also that avoidance and thought suppression might work and feel better in the short run, but in the long run, it comes back. I think I've said this recently, that thoughts are not a stick, thoughts are a boomerang. So the harder you throw it away, the faster it's gonna come back at you. I don't know that I came up with that myself, but I've been saying it recently. And that all of these things, we're experiencing avoidance, hypervigilance, they're all signals that the trauma is unfinished business, that the memory has not been processed. So the goal of revisiting is to really, the key of it is to process and organize the traumatic memory. There's some research that shows that the more severe PTSD is associated with the readability of the trauma memory. So they had somebody write out their trauma memory, and individuals with PTSD who went on to develop chronic PTSD, the readability of the memory was like at a second grade reading level, right? Like as if a second grader had written it out. And so it's really this idea that it's this disorganized jumble in your head, which just makes anybody more anxious. Again, think about your filing room or your basement. You know, going down in there and thinking about cleaning it all out makes you pretty anxious. But this has to do with the trauma memory. People learn that memories are not dangerous. And I think that's an important thing, that it's an important lesson for people to learn. People really gain a lot of confidence. If you think going back to Wawa makes you feel confident, what about being able to sit with the memory? The lessons that you learn about your own capability are amazing. With the habituation to the memory, it allows the individual to start evaluating the data that's within the memory, right? There are points in a traumatic event, where people do things that are counter to the idea that when they tell themselves they didn't do anything. That are counter to, I think I used the example on Monday, somebody who might have been in combat and saying, I should have prevented the ambush from happening, right? I should have done more, I should have known. But when they sit with the trauma memory and they habituate, they really start to learn that they were just like a dumb 18-year-old. That's like a direct quote from an individual that I served. He goes, I was just 18. Like 18-year-olds are really, really stupid. Actually, that guy, I married up in Vivo exposure. I asked him to go to a local, I said, is there a place nearby where you could see like 18-year-olds? And he goes, yeah. And he went and sat at the college and watched them walking around. And then he went home and listened to his Imaginal exposure. And he came into the next session. He goes, man, Doc, I was 18 years old. And 18-year-olds are so stupid. And he goes, and I know they got all this stuff these days, but I'm telling you, we were just as stupid back then as we are now. So as we start to habituate to the memory, and I don't need to avoid the memory, I can actually start to make sense of what actually happened. What we really want to focus in on is this idea of effective engagement. We know that when people over-engage, which is really rare, people freak out that individuals will over-engage in a memory, but people are more likely to under-engage. Remember, this is a disorder where people have a memory pop into their mind, and then in reaction, they whack the memory out of their mind as fast as possible. So under-engagement is a much bigger culprit than over-engagement. There's a very small group of people who over-engage. So when we think about emotional engagement, right? So there's high emotional engagement, there's low emotional engagement, and then we think about, right, information processing. So think about it. If you're really, really freaked out, you're not processing any information really well, right? But then again, on the flip side, if you're not engaged at all, the trauma memory isn't activated. So basically, there's this like very wide range, right? From under engagement, and here's over engagement. But you kind of want to be somewhere in here, right? You want to be engaged, emotionally engaged, so you get some information processing. It's it's not as hard as it seems, but it's something that we want to keep track of. And so when we're also thinking about psychosis, really the only thing I'm looking for is that I can get somebody to engage in the exposure and work at it so that they can start processing the memory with me. So as we're talking about imaginal exposure, we really are going to use a lot of these analogies. I gave you guys the analogy already of the filing room. There's also the example of a movie, right? So I oftentimes, a movie or a book, you kind of heard the book one already. But the movie one goes like this. Have you ever watched a scary movie? Or you or any of your friends ever watched a scary movie? If they say no, then I don't know where they live. But they go, yeah. The first time you watch a scary movie, how do you feel? Scared. It's scary, right? Have you ever, like when you were a teenager or younger, have you ever watched a movie like a million times, like just watch the same scary movie like 100 times? A lot of people have, it's sort of like a very teenagery thing to do. Or if you worked at the movie theater and you started the films up and you watched it like 100 times. The 100th time you watched that movie, how scary would it be? They're like, no, not scary at all. It wouldn't be scary at all. right? And you might even start noticing things that are part of the movie, right? The gun was in this hand on this scene, and this hand in another scene. But you can't notice those things until you kind of just get used to the movie. That's what we're going to do to the trauma memory. The other piece of psychoeducation, we do this in the second session. This is a very long piece of it. Usually by the time people, if anybody's ever done prolonged exposure, most people say after the third session, they're relieved because all of the all of the information, psychoeducation kind of is over. But it's really talking about just the common reactions that people have to trauma. And it really is, it's a half-hour conversation and putting it all into perspective. It really validates and normalizes a person's experience. It also instills hope, you know, where I've had a lot of people say, so wait, are you telling me all of that stuff's gonna go away if we get the PTSD to go away? This all's related to PTSD? And I'm like, possibly, yeah. Well, then I'll do that exposure thing. And so it really provides a lot of hope. It also, for our individuals that we're serving, without challenging some of the misinterpretations they have, we're giving them an alternate explanation as to why their heart races or why they're always looking around them. Maybe it's not having to do with the psychosis. Maybe it has to do with this reaction following a trauma. So that's sort of the down and dirty, really quick through exposure. What we're going to do, that untreated PTSD is going to affect all the different parts of an individual's life. Exposure really is a powerful and efficient cognitive intervention. It's also highly portable, right? So we've seen it works really well in the ivory tower. It's worked well in out in the community. So places like Women Organized Against Rape, JJPI, they've done it and they've gotten actually on some of the measures better outcomes than the clinicians in the ivory tower, which is sort of neat. As we start to habituate, a lot of those non-fear-based emotions like shame, guilt, anger, grief, disgust, those can start to process because we can start to shift we can start to correct our beliefs or correct our cognitions around those. And so all of the problems that go along with PTSD, many of the problems that go along with PTSD can be addressed directly through the exposure. And really that individuals can recover from PTSD and live a really meaningful life. And so this is a nice focused piece that we can have in our pocket as we're serving the individuals that we want to serve. A reminder, Monday there's no webinar, but Friday is Families Part 2. The webinar will be posted. If you're off and you're not doing something else on Monday, if there's ones that you've missed, they're all posted. And so you can go and check those out. And with that, hi, Erin. Great present. Thank you. I'm wondering about people coming out of a psychosis who have trouble discerning whether there is a traumatic memory or real or not. Does the trauma memory that we activate in session have to be true? So there's a really interesting study where they found that people who were held up and believed that they were at gunpoint, but actually it was just the person's finger in their pocket, that you can develop PTSD to that, right? Even though you weren't actually in any real danger. So one of the things that I've oftentimes, many times what I've found that can be really helpful is I do a lot of the activation and have people start moving toward their aspirations, get them moving forward. And if all of a sudden you start noticing that the memory sort of dissolves on its own, then we don't necessarily need to go ahead and do the you don't necessarily have to go and do exposure. For other people, if they just have a memory, like I think I said on Friday, of the FBI coming and banging on their door and coming to arrest them, because that might have been how they got hospitalized the first time, and that was really terrifying, then we might kind of go through that. One of the things you may start to see is it sort of dissolve, sort of like, not dissolve, but sort of start to lose its integrity, like its togetherness, right? So that would be it. Is that
another question, Dr. Brinen? Just the comorbidity with substance abuse. So at what point do you treat the PTSD, but also the substance abuse that typically goes, that's correlated with the with trauma? So what are your thoughts on that?
So that was one of the studies I was in. That was really fun. As a therapist, I was part of the retreat team when they did, it was the PE-ALK study. So the PE-ALK study had to do with, is basically treating comorbidly prolonged exposure and alcohol use disorders. So I was a part of the PE. It was really exciting being part of the PE-ALK study. And what they did is they basically detoxed people of alcohol, I think on Friday, and by Monday they were into prolonged exposure. And really the idea was to look at it, if you think about it, substance abuse is really just another form of avoidance, right? Alcohol, if I drink a big bottle of vodka, it's a good way to avoid my feelings. I mean, now granted, there's all these bad parts that come along with it, but your deep breathing may work, it may not work, but that alcohol sure works, right? The drugs and alcohol are really predictable. I know that might seem like a horrible thing to say, but it's accurate, right? They are predictable. And that's why people go to drugs and alcohol, because they're really predictable. And so if we start to pose it as, pose this whole idea as, it's just another form of avoidance. And yeah, man, it works. All avoidance works. It works in the short run, but in the long run, it's actually keeping you stuck. So what if we could figure out a way so that you didn't have to avoid? Now, here's the bummer, right? If we do exposure and then we avoid at the same time, ain't gonna work well, right? If we do the imaginal exposure and then you take 3 Xannies, ain't gonna work well. If you listen to your imaginal exposure while you're drinking a pint of gin, it isn't going to work well. And so saying, is there a way for us to put it off listen, prolonged exposure takes 9 to 15 sessions. So if you're doing it twice a week, we're talking, can we put it off for 2 months and see? And maybe at that point, you can return back to using drugs or alcohol in a more moderate way. Maybe you can't, I don't know. But I think once the dust settles from PTSD, you might not need it as much, right? And just seeing or schedule it. I think when we've gotten, it's funny, early on in when it first came out and they first started doing exposure therapy, it was like super rigid. So they were really rigid, and then they realized we live in a world where people prescribe benzodiazepines, and we live in a world where there's alcohol in the world. So what they started doing with even things like, and this is true in OCD treatment and other places, they just started talking with the people a little bit more about being like, okay, great. So if you really still need the benzodiazepine and you really are not interested in doing it. So 2 things. One, it can't be a PRN benzo, right? So you can't, so things like Xannies, Valium, I shouldn't call it Xannies, Xanax, Valium, Ativan, right? You can't be like, I'm anxious, right? So no PRN, but some people are on a Klonopin, which is a long acting, so they take it twice a day. And so what they started saying was, okay, take it at the scheduled time. Don't do your exposure right after it, stuff like that. And same thing for alcohol. If you can moderate your alcohol use, let's try it. What are you willing to do? But let's start moving toward it. But the problem is if you use avoidance, it's like I'm trying to think, it's essentially like putting the burn cream on and then, getting hot, putting burn cream, it's like we're just sort of, we're like taking an antibiotic and then exposing myself to the illness again. Antibiotic, it just seems like it seems like you're going through a lot of pain and not going to get any of the benefit. And so just looking at it as a part of the avoidance thing. But yeah. And the problem that we get into is, a lot of people go to drug and alcohol treatment. They go, oh, no. You can't work on drug and alcohol until you take care of your mental health. They come over to mental health and they go, oh, no. We can't treat you until you take care of your drug and alcohol problem. And these weren't people who were motivated to do it to begin with. So they're like, forget this. I'm out of here. And they leave, and it's really a sad case. So treating it early on. So, and I'm probably mispronouncing it, Nuria?
Yep, it's Nuria. Actually, Aaron, can I just jump in and say what I wrote, since I noticed I had a lot of errors in there?
You were asking basically, how do you deal with it if it's childhood trauma and it's been there for a really long time, like 20, 40 years?
I mean,
Is that
so
it?
it's not, yeah, it's essentially like 20 years and the person is like deep in avoidance, and it's also like difficult to tap into those childhood trauma memories. I'm wondering if some of that is like developmental versus just,
Mhm.
years of building that
Right.
avoidance.
Great question. So the research that they have actually is that there's no difference in dropout rates, in effectiveness for people who dropout rates and effectiveness for people who have childhood sexual abuse, CSA, or childhood traumas, versus somebody who has a more recent trauma. And so they sort of all work. You need discrete memory. So if somebody goes like, I just feel like something bad happened to me when I was a kid, that isn't going to cut it. And ultimately we might want to sort of like think about what is leading to those types of things. But if a person has a trauma memory of something that happened to them, horrific that happened to them when they were a child, it works just as well. Again, this isn't about coming up with like a record for court. It's really about just sort of revisiting it and learning that they don't have to avoid the memory. When we get into in vivo exposures, that part of it where we really think about that it's ingrained, a lot of times we go, what are things that you're inviting, where are there places you don't go, or the things you don't do? We oftentimes ask, are there things that you don't do that, like, it's fine to do, but you just don't do it because you just don't do it? And people all go, yes. And then, so those are, because that's that sort of like, they've just gotten used to like living in this world of trauma, of sort of trauma avoidances. And so we put those on the list. And it really is the same process of working through it. For somebody who has prolonged trauma throughout their childhood, frequently when you ask which memory haunts you the most, it's surprising how oftentimes people they have that one, right? I've sat through a lot of supervision, and I've treated a lot of cases where, they list this litany of horrible, traumatic, history of trauma. And then when you ask what's the one that haunts you the most, they go, this one. And if somebody has like sort of like, well, there's this one and then this one pops up and this one, what we usually do is we start with the worst memory. Well, we can ask, we do it collaboratively, but we usually go with the worst memory and work all the way through it. And then the other ones usually work through pretty quickly. Because remember, it's not about habituating to the memory, it's habituating to the idea that memories are dangerous. So once you learn the lesson that memories aren't dangerous, it all sort of, you might just need to work through it. Other people, they just start doing them anyway. But a lot of people with the childhood sexual abuse, you're talking about a lot of shame and guilt. And what starts to happen is you habituate to it, that life that life that's wrapped around being ashamed of who you are and what happened. As that starts to correct itself, as you start to learn that it wasn't my fault, as many times as people have told you that it wasn't your fault, you couldn't have done anything, you start to learn that lesson, and but you learn it from the inside, and it's powerful. It's powerful for me to see. I really believe in all of the science, and I never lose the fact that it just feels so magical when you use the really good science. But yeah, a lot of that research shows that a lot of the research shows that people do just as well who have a history of childhood sexual abuse. Therapy that had about 26 sessions before the exposure therapy, people most often dropped out before getting to the exposure. That's really interesting. Did you do STARE? Is that what it was? By Marilyn Kloicher?
Yeah, that's what I used to do.
Yep. So it's really interesting. I think the best thing I ever heard was my mentor. We were presenting at ISTSS, which is a trauma conference. And she just said that the idea that we have an a priori decision that you can't do this with certain cases. Let's just do a functional analysis. Let's find out. And so that is, any other questions? Thank you for being with me on Friday. Awesome. So, but all be well, take care of yourselves, and I will see you guys next Friday. Bye.